So let's start with the first case. This was a 4-year-old female, fell from stairs, had a severe high energy injury, 1-day-old injury. What should be done? She has a displaced proximal humerus fracture, and these are the options. We can have you can start answering. Is it closed reduction and U-slab? You do a closed reduction K-wiring with such a grossly displaced fracture. You open reduction if it is not coming, or just give an arm pouch without reduction. All right. So I think it's a tie between closed reduction and U-slab and arm pouch without reduction. What was done was arm pouch without reduction. This is at 4 weeks, showing good callus, and this is at 6 months, a completely healed and remodeled fracture humerus with proximal humerus with excellent range. So this is the second case. A 6-year-old male had fall on outstretched hand. This is a fresh injury, fell a few hours back. There's something wrong, has some lateral condyle tenderness, significant soft tissue swelling. What should be done? So these are the options. You give an in situ cast. Second option, closed reduction percutaneous pinning. Third is open reduction. Or fourth is you're not happy with this, you need some more information. So let's start. Great. So can someone point out which information you want? Superb. So new information which is needed is an internal rotation oblique X-ray. You can see that with this X-ray, there is a gross displacement of the fracture, and that needs some surgery. So this was a 6-year-old male, fall on outstretched hand. This comes after 2 weeks of injury with a displaced and angulated distal radius physeal injury. What should be done? About 6-year-old with a 2-week-old injury. So these are the options: closed reduction and internal fixation with K-wiring, open reduction with K-wire, intrafocal reduction and K-wiring, and leave it as it is. You can start. All right. So everyone agrees that we should just leave it as it is. There are few people who want to fix it. What was done? It was just left as it is. It has healed completely and completely remodeled. So this is what Dr. Sandeep discussed. Neonate with a birth trauma with this injury. The primary orthopedic surgeon knew that we have to treat a very young child with a hip spica, and this was done. And the child came to us, to the orthopedic surgeon with this X-ray. What should be done? You can see that there is some amount of angulation. Now what to do? Is this acceptable? We can start the quiz. If this is acceptable, we can continue the same. Should we wedge the cast? Should we shift to a simpler Pavlik harness? Or this is not acceptable at all, we should fix it with a closed reduction, with a tense nailing. Let's start.
Get ready to the countdown.
All right. So many of them. A and C are running close together. It's a close competition. So almost everyone, about half of them have said acceptable, continue the same. The primary orthopedic surgeon continued the same, but as you could see that there was a significant angulation, almost a 90-degree angulation at the first day, and there was significant angulation which continued over time and which did not remodel. So this was the fifth case. This is a 7-year-old male, fall on outstretched hand. This was the day 1 X-ray, and he came to us after 4 weeks with a cast with this X-ray. So this is today's X-ray at 4 weeks post-trauma with again a grossly displaced radius ulna. What should be done? Let's have the options, which are closed reduction and internal fixation with K-wiring. Second, you don't accept this, you do an open reduction with K-wiring. Third, you say that we have to fix it accurately and open the reduction with plate. Or fourth, you accept and continue.
Get ready to the countdown.
Perfect. So, the third option, thankfully, no one has written open reduction and plating. So most of it have them written accept and continue. This was done, and the child has remodeled almost completely at 6 months and has a full function and full range of motion. So this is a 5-year-old male, fallen outstretched hand. This comes with a fresh injury, has an angulated radial neck fracture. What should be done? Close reduction and casting, intrafocal reduction and K-wiring, metazew intramedullary nailing to reduce the angulation, or an in situ cast. Let's have the voting. This was a 5-year-old with a fresh radial neck fracture.
Get ready to the countdown.
Are we voting? Yeah. We can go ahead. We can decrease the time for the voting. Yeah, so what was done? So this was a 6-year-old boy with only about a 30-degree angulation. This was treated with just an in situ cast and has a full range of motion at 2 years post-trauma. This was an 8-year-old boy, has a fallen outstretched hand 1 month back, comes with persistent anterior elbow pain. Sorry, the X-ray was changed. Sorry. Is this a normal X-ray? You give just an annual. So these are the options. Second is it has probably a fracture olecranon. Give a slab. Do an MRI or do a better X-ray. Yeah. Perfect. So better X-ray, you can see the two lines, the Mubarak's line and the radiocapitular line, which was not in place. So this was missed montagia, and this was what needed to be done. So this was a 5-year-old male, fallen outstretched hand, was treated with close reduction and strapping elsewhere. And this was the X-ray which was sent. This was the photo which was sent to me by the primary orthopedic surgeon, saying, "Okay, I have done this," and this was at the time of reduction. What should be done? The options are: you continue the same. This is the post-reduction X-ray with a strap. Continue the same for 4 more weeks. Reduce it and give a strap. Close reduction and internal fixation with wire, or open reduction with wires.
Can you go back to the previous?
Yeah. So this was the pre-reduction X-ray. This is pre-reduction, and this is after reduction. And after which the orthopedic surgeon has then given a strap. 3 days old. Let's see the
Get ready to
results.
the countdown.
Continue the same for 4 weeks, I think, is the winner here. Vascularity, compartment negative, neurology normal. So he continued the same thing. He said this is absolutely perfect, and sent it to me after 1 year with this, with a cubitus varus. So he had a medial collapse and had a cubitus varus with a hyperextension deformity and restricted flexion.
Mandar, if you get that case to you, what you would have done is a close reduction and a fixation.
I will do a fixation, yeah.
That's the message.
Yeah. So that's what. So if you don't fix, this can happen. Yeah, so this was a 13-year-old female, twisting injury of the ankle and inability to bear weight. What should be done? X-ray is normal, just give an analgesic. This is an undisplaced fracture, give a BK cast. Do just elastocrape and ice application, and further evaluation or surgery. I think there's one option less. So all right. So most have said further evaluation and surgery, and that was what was done. With the CT scan, you can see that it's a displaced stylo fracture which requires fixation. Last two cases, this was a 9-year-old male, had a history of injury 4 years back, comes with instability and pain on weight-bearing activities like gymnastics. The range of motion is full and ulnar nerve is normal. What should be done? Open reduction internal fixation, in situ screw fixation, open reduction with bone grafting, or it's full range of motion, कुछ नहीं है उसको, leave him alone.
Get ready to the countdown.
So full range of motion, leave alone is winning. क्या? Yeah. So basically he had pain on loading. So what was done was an in situ screw fixation. And last case, what Dr. Sheetal said, twisting injury into the right ankle 10 days back, 10-year-old male. He is walking comfortably. This, I got a call from an orthopedic surgeon saying, we are planning to fix him. What should I do? I said, don't shift him out. So what is this? Come to IFICS. All right. Yeah, so leave it. So this is an accessory bone. We should not treat it. So thus to reiterate, fractures in children are very diverse. Most heal with minimal intervention. Others require some specialized intervention. Some heal in spite of us and maybe not because of us. And important to have the wisdom to distinguish between these. And for this, we have IFICS 2023 with the team IFICS of Dr. Sandeep Patwardhan sir, Dr. Premal sir, and Dr. Taral Nagda sir. And we have the organizing team led by Dr. S. Rajasekaran sir and Dr. Venkatadass. Welcome to IFICS. Thank you so much.